Bismillahirrahmanirrahim. I am Professor Dr. Sarfraz and Sayyid, Head of I Unit 2, Punjab Medical College, Faisalabad Medical University, Faisalabad. Today we are going to discuss about the orbital inflammatory diseases. These has been classified into the infectious and non-infectious. The infectious diseases are pre-septal cellulitis, orbital cellulitis, fungal orbital infections, dacryocystitis, and infective dacryoadenitis. Non-infective are idiopathic orbital inflammatory disease, also called the pseudotumor of the orbit, and non-specific orbital inflammations. Tolosa-Hunt syndrome, orbital myositis, sarcoidosis, vasculitis, associated with PAN, which is polyarteritis nodosa, and also vaginal granulomatosis. The causative organisms in children are Staph aureus, Streptococcus, and anaerobic species. In adults, it is Staph aureus, E. coli, Streptococcus pneumoniae, mixed flora. The infection may spread from the periorbital or intraocular structures, or there may be direct inoculation of the bacteria into the orbit, usually during surgery or trauma. Mostly the hematogenous route may result into the bacterial embolization and causing the orbital cellulitis. There is orbital cellulitis has been mainly divided into the preseptal and the orbital cellulitis. The preseptal, the infection of subcutaneous tissue anterior to the orbital septum. The patient may present with painful lid swelling and is often non-pyrexial. There is swelling of the lid which is firm, tender, and red. The visual acuity, the pupillary reaction, and extraocular movements are unimpaired. The proptosis and chemosis of the conjunctiva is usually absent. Usually, the diagnosis is clinical, no investigations are required, but if there are orbital cellulitis or lid abscess suspicion, we should go for an imaging with CT or MRI. The treatment is with oral antibiotic like co-amoxiclav, and analgesics are required usually for the pain. In case of severe infections, the intravenous antibiotics may be required. The orbital cellulitis is a serious infection of soft tissue behind the orbital septum, which can be sight or life-threatening. The causative organisms are usually Streptococci pneumoniae, Staph aureus, Streptococcus pyogenes. Infection usually spreads to the orbit from paranasal sinuses, especially in case of ethmoid sinusitis, or it may spread from the preseptal cellulitis. The dental infection spread into the sinuses, maxillary sinus, and from there it can spread into the orbit. The trauma and ocular surgeries may cause a direct inoculation of the infective material. The hematogenous spread from distant resources may spread to the orbit. The patient presents with the pain, proptosis, diplopia, loss of vision, and general symptoms like fever, headache, malaise, nausea, vomiting, prostration. Usually, there is lid swelling, which is tender and firm, and erythematous. There is conjunctival chemosis. Proptosis is common. It may be non-axial, but if there is an abscess, it may become it may it is usually non-axial when there is an abscess. The proptosis may result into severe corneal complications. There is painful ophthalmoplegia due to the muscle inflammation and nerves involvement. The optic nerve compression may cause decreased visual acuity, color vision impairment, relative afferent pupillary defect, optic disc swelling, and choroidal folds. Now, this is a optic disc swelling. Later on, the optic disc may become atrophic, and you can also see the swelling within opticociliary shunt if there is a chronic um, orbital cellulitis, and there may be the choroidal folds are also there on fundus examination. The lab investigations, we need a complete blood count. The blood culture should be sent for to rule out the hematogenous route. The ESR is performed and ASO titer for streptococci infections. The imaging studies are required. The ultrasound is required to rule out the orbital myositis, and if there is any foreign body or abscess, the ultrasound may detect it. High resolution CT of orbit, sinus, and brain is performed to confirm the diagnosis and to rule out the subperiosteal or intracranial abscess. In some cases, when there is meningeal or cerebral signs, we may have to perform a lumbar puncture. You can see in this a CT scan where you can see a subperiosteal abscess uh, with the medial wall or of the orbit. The complications of orbital cellulitis may be an optic neuropathy, central retinal vein occlusion, exposure keratopathy, intraocular spread of infections, orbital abscess formation, orbital apex syndrome, cavernous sinus thrombosis. Sometimes the orbital abscess it may discharge through the skin. Management of the orbital cellulitis, we need to have the hospital admission, intravenous antibiotics of triple regimen is required to cover the gram positive, gram negative, and anaerobes. The intravenous antibiotics are usually continued till the patient is apyrexial for 4 days, followed by 1 to 3 weeks of oral antibiotics. The anti-inflammatory drugs are required for the pain, and nasal decongestants are required if there is a pathology of sinusitis. Monitoring of optic nerve function is mandatory and should be performed 4 hourly by doing visual acuity, color vision, and pupillary reaction. The surgical intervention is required when there is suspicion of orbital abscess or foreign body, there is progressive loss of vision, the extraocular movement is defective, there is worsening of the proptosis, and non-reduction in the size of abscess on CT scan within 48 to 72 hours of antibiotic therapy. The surgery should be performed in case of cellulitis without abscess when the visual acuity is less than 612 and the appropriate medical treatment fails to improve the condition. Or it should be performed when the visual acuity is less than 612, followed seriously, expectantly, frequently with more conservative management. The surgical procedures are like free incision into the abscess, subperiosteal abscess drainage. The both the orbit and the paranasal sinuses should be drained, and in case of brain abscess, the neurosurgeon may perform a craniotomy. Complications of the fungal mucormycosis are retinal vascular occlusions, multiple cranial nerve palsies, visual loss, intracranial abscess, cavernous venous thrombosis. The treatment is correction of underlying metabolic defect, intravenous antifungal treatment with amphotericin B, posaconazole, wide excision of devitalized and necrotic tissue, exenteration in unresponsive cases, adjunctive hyperbaric oxygen may be helpful. Idiopathic orbital inflammatory diseases, these are also called non-specific orbital inflammation or orbital pseudotumor. It is a common it is an uncommon disorder characterized by non-neoplastic, non-infective space occupying orbitals infiltration with inflammatory features. The process may preferentially involve any or all of the orbital soft tissues. Histopathological analysis reveals pleomorphic inflammatory cellular infiltration followed by reactive fibrosis. Unilateral disease is typical in adults, although in children bilateral involvement may occur. Intracranial extension is rare. Simultaneous orbital and sinus involvement is also rare and may be a distinct entity. The diagnosis can be the clinically from symptoms which typically consist of acute or subacute ocular and periocular redness, swelling, and pain. Systemically, the symptoms are common in children, which may have pyrexia up to 50% of cases, but it is rare in adults. The patient on examination present with congestive proptosis, mild to severe ophthalmoplegia, features of optic nerve dysfunction, which is reduced visual acuity, relative afferent pupillary defect, and central or sequocentral scotoma. Inflammation involves the posterior orbit. There may be optic disc swelling as well. Choroidal folds, if present, may be associated with a reduced vision, but optic neuropathy must always be suspected. The natural history of the inflammatory process is very variable. Sometimes there is spontaneous remission after a few weeks without sequelae. Sometimes there is intermittent episodes of activity, usually with eventual remission. Sometimes they present with severe prolonged inflammation, eventually leading to the progressive fibrosis of the orbital tissues, resulting in a frozen orbit characterized by ophthalmoplegia, which may be associated with ptosis. The visual impairment is caused by the optic nerve involvement. Here is CT scan. You can see the medial rectus inflammation in this case, and it also causes the compression of the optic nerve on this side. Its course may be an acute, non-recurrent involvement that resolves spontaneously within 6 weeks, or there may be a chronic disease characterized by either a single episode persisting for longer than 2 months, often for years, or recurrent attacks. Investigation consists of primarily of the MRI or CT scan, which show enlargement of the affected muscles with or without involvement of the tendons of the incision. This is in contrast to the thyroid eye disease related muscle enlargement in which the tendon is always spared. Additional investigations may be required in some cases. The treatment is aimed at relieving discomfort and dysfunction, shortening the course, and preventing the recurrences. Non-steroidal anti-inflammatory may be adequate in mild disease, but systemic steroids are generally required and usually produce dramatic improvement, although recurrence is seen in 50%. Radiotherapy is also effective, particularly in limiting the recurrence. Acute dacryoadenitis may be idiopathic, or it may be because of the viral infections, bacterial infections, idiopathic orbital inflammatory disease. The chronic conditions such as sarcoidosis, Sjogren's syndrome, thyroid disease, and some chronic infections usually give a less acute onset, and involvement can be bilateral. Diagnosis is by presentation as acute disease with the rapid onset of discomfort in the region of the gland. Lacrimal secretion may be reduced or increased, and discharge may be reported. Lacrimal secretion may be reduced or increased, and discharge may be reported. There is S-shaped ptosis due to the swelling of the lateral aspect of the eyelid overlying the palpebral lobe. There is dystopia, which is the downward and inward displacement of the globe because of the enlargement of the orbital lobe. The diagnosis is by looking at the features of non-axial proptosis, the signs of the orbital disease, tenderness over the lacrimal gland, injection of the conjunctiva overlying the palpebral lobe. The chemosis may be present. There may be local preauricular lymph node enlargement. The investigations and treatment, the CT scan shows enlargement of the gland and involvement of the adjacent tissue without bony erosion. Later suggests a tumor. If there is bony erosion, there is tumor. Biopsy is sometimes required to rule out the tumor. The treatment varies according to the cause, but in many cases it is not required. Tolosa-Hunt syndrome is a rare idiopathic condition caused by the non-specific granulomatous inflammation of the cavernous sinus, superior orbital fissure, and/or orbital apex. It is diagnosed but it is a diagnosis of exclusion and should be investigated fully. The presentation is with ipsilateral periorbital or hemicranial pain and diplopia due to one or more ocular motor paresis with pupillary and eyelid involvement in many cases. Proptosis, if present, is usually mild. Sensory loss along the distribution of the first and second divisions of the trigeminal nerve is common. The patient may be pyrexial. Diagnosis is with imaging together with other investigations to rule out identifiable causes, including neoplasia. Treatment is with systemic steroids and other immunosuppressants as necessary. The clinical course is characterized by remissions and recurrences. Wegener's granulomatosis is an idiopathic multisystem granulomatous disorder that may involve the orbit, often bilaterally, usually by contiguous spread from the paranasal sinuses or nasopharynx. Primary orbital involvement is less common. The possibility of Wegener's granulomatosis should be considered in any patient with bilateral orbital inflammation, particularly if associated with the sinus pathology. Anti-neutrophilic cytoplasmic antibody is a useful serological test. Ocular features include scleritis, peripheral ulcerative keratitis, intraocular inflammation, and retinal vascular occlusions. Treatment is with cyclophosphamide and steroids, which are usually effective. In resistant cases, cyclosporin, azathioprine, antithymocyte globulin, or plasmapheresis may be useful. Surgical decompression may be required for severe orbital involvement. Cavernous sinus thrombosis. It is clotting within the cavernous sinus. It is caused by the infection from the sinusitis, orbital or preseptal cellulitis or otitis, more common in diabetic and immunocompromised patients. There is a high mortality rate of 20% treated and up to 100% untreated. Features are of rapid onset and may include severe headache, malaise, nausea, and vomiting, altered sensorium. Unilateral or often bilateral proptosis is sometimes seen. There may be chemosis, congestion of the facial, conjunctival, and retinal veins, reduced vision, and signs resulting from the compromised function of the third to sixth cranial nerves which run through the cavernous sinus. The diagnosis is with imaging, especially MRI and MRI venography. Systemic investigations for infection is also performed, including lumbar puncture. The treatment consists of intravenous antibiotics and sometimes surgical drainage. Carotid cavernous fistula. A carotid cavernous fistula involves the development of an arteriovenous fistula between the carotid artery and the venous cavernous sinus with a rise in the venous pressure in the sinus and structures draining to it. Ocular manifestations occur because of venous and arterial stasis around the eye and orbit, increased episcleral venous pressure, a decrease in the arterial blood flow to the cranial nerves within the cavernous sinus, and it has been classified into two, the direct and the indirect. The direct or high flow shunts. The carotid artery blood passes directly into the cavernous sinus through a defect in the wall of the intracavernous portion of the internal carotid artery. It occurs as the result of trauma in 75% head injury, including the surgery, spontaneous rupture of an intracavernous carotid aneurysm or an atherosclerotic artery, the latter frequently in a middle-aged hypertensive women. Spontaneous fistulae usually have a lower flow. Indirect arteriovenous shunt. The intracavernous portion of the internal carotid artery remains intact. The arterial blood flows through the meningeal branches of the external or internal carotid arteries indirectly into the cavernous sinus. And the clinical features are more subtle than in a direct fistula, such that the condition may be overlooked. The spontaneous rupture of an atherosclerotic artery or a congenital malformation is the usual cause and may be precipitated by minor trauma or straining. Connective tissue and collagen vascular disorders can be associated. The diagnoses in are different in the two types. In direct, the patient present after days or weeks of head injury with a classic triad of pulsatile proptosis, conjunctival chemosis, and a whooshing noise in the head. In case of indirect carotid cavernous fistula, the gradual onset of redness of one or both eyes is a typical presentation caused by conjunctival vascular engorgement. In case of direct fistula, we can see the immediate visual loss due to the ocular or optic nerve damage at the time of head trauma. There may be delayed visual loss as a result of exposure keratopathy, secondary glaucoma, central retinal vein occlusion, anterior segment ischemia, or ischemic optic neuropathy. These are the signs in the direct fistula are usually ipsilateral to the fistula but may be bilateral or even contralateral because of midline connections between the two cavernous sinuses. Marked epibulbar vascular dilatation may also be seen. There is a chemosis that edema, usually hemorrhagic, particularly in the early stages. The proptosis is pulsatile associated with bruit and a thrill, both of which can be abolished by ipsilateral carotid compression in the neck. There is raised intraocular pressure due to the elevated episcleral venous pressure and orbital congestion, and sometimes there is angle closure glaucoma. The anterior segment ischemia may be characterized by corneal epithelial edema, aqueous cells and flare, and in severe cases, iris atrophy, cataract, and rubeosis iridis. Ptosis is due to the third nerve involvement. Ophthalmoplegia is seen in 60 to 70% of the patients due to the ocular motor nerve damage from the initial trauma, an intracavernous aneurysm, or the fistula itself. The sixth cranial nerve is most frequently affected because of its free-floating location within the cavernous sinus. The third and fourth nerves situated in the lateral wall of the sinus are less frequently involved. Engorgement and swelling of the extraocular muscles may also contribute to defective ocular motility. Fundus examination may show optic disc swelling, venous dilatation, and intraretinal hemorrhages from venous stasis and impaired retinal blood flow. Venous hemorrhage is rare, vitreous hemorrhage is rare. Here you can see this the multiple hemorrhages over the retina because of the venous um, engorgement and venous stasis. This occurs in the central retinal vein occlusion, especially in the non-ischemic type. Here you can see the congestion and chemosis of the conjunctiva, which is hemorrhagic, and you can see also the lids are swollen. Both the lids are swollen. You can see there is engorgement of the vessels because of the carotid cavernous fistula leading to the anterior segment ischemia. You can see these corkscrew vessels, episcleral uh, veins. And also here there are dilated tortuous vessels. You can also see the tortuous vessels, dilated vessels over the fundus as well. The signs of the indirect is a milder epibulbar vascular dilatation than with the direct fistula, exaggerated ocular pulsation. This readily detected on slit lamp applanation tonometry. The presence of corkscrew epibulbar vessels is a common subtle later sign. These are not pathognomonic and can be found in normal eyes. Raised intraocular pressure, often bilateral but higher on the side of the fistula. Proptosis and bruit are mild if present. Ophthalmoplegia caused by sixth nerve palsy or swelling of extraocular muscles is marked. In marked cases, fundus may be normal or manifest moderate venous dilatation with later tortuosity. As with corkscrew conjunctival vessels, this is not pathognomonic. Investigations are with CT scan and MRI, which may demonstrate prominence of the superior ophthalmic vein and diffuse enlargement of the extraocular muscles, though these may only be visible with direct fistula. Orbital Doppler imaging may show abnormal flow patterns, particularly in the superior orbital vein. Definitive diagnosis may involve selective catheter digital subtraction angiography, especially in mild dural fistulae. CT and MRI angiography can be useful. The treatment ocular complications may require specific measures in addition to the treatment of the fistula itself. Neurological subspecialist opinion should be sought at an early stage even if the features are mild, as some fistula patterns, such as cortical venous drainage, carry a high risk of stroke. Direct The treatment of direct fistula in most carotid cavernous fistulae are not life-threatening. The organ at the major risk is the eye. The surgery is indicated if spontaneous closure does not occur. A post-traumatic fistula is much less likely to close on its own than a spontaneous fistula because of higher blood flow. Treatment is likely to consist of a transarterial approach to repair the artery with a coil or occlude the involved sinus with a coil balloon or other remedy. Craniotomy for arterial repair is occasionally needed. In case of indirect fistula, the treatment, if required, usually involves transvenous occlusion of the involved sinus. Spontaneous closure or occluding thrombosis, sometimes up to 50% occurs. Intermittent carotid compression under the specialist supervision has been reported to increase the likelihood that this will take place. You can see the the superior ophthalmic vein enlargement with the angoid muscles. Early arterial phase catheter angiogram shows filling of the cavernous sinus and superior ophthalmic vein. Following deposition of coils in the cavernous sinus, the fistula is closed and there is no retrograde flow in the superior ophthalmic vein. Thank you very much.